This is the Authority Company Podcast, conversations with leaders who are designing the future. Hola, I'm Joe Pardavila, and today I'm going to spend some time with Dr. Lawrence Rosenberg, President and CEO of Jewish General Hospital and the Integrated Health and Social Services University Network for West Central Montreal, leading one of Canada's top-performing healthcare systems. He's a transplant surgeon, PhD scientist, and global voice in value-based healthcare, and was named one of the world's top hospital CEOs by Newsweek. He's also the author of the new book, From Vision to Vitality, Building Transformative Healthcare Organizations, which is a roadmap to break through bureaucracy and deliver care that works for patients, providers, and systems. Dr. Rosenberg, welcome to the podcast. How are you, sir?
I'm great. Couldn't be better. And thank you for the opportunity of being here.
Well, I appreciate you being here today. And one of the things that I want to get a quick level set as we begin this conversation is you're in the Great White North in Montreal in Canada. I'm here in the States. What are some of the main differences, just so people get an idea of what healthcare is like in the United States and Canada? Whatever a couple that you can give out, just so we can have an idea of what we're talking about today.
Well, I can give you two. Canada is probably one of the last Western countries in the world where the government has a healthcare monopoly, being both the monopoly payer and the monopoly provider of care, since they run the healthcare system. That's not true in most other places. Most other Western countries, including the US, have hybrid healthcare systems, so partly public, partly private, to different degrees. There is a private healthcare industry in Canada which is trying to come into existence. It's difficult because most of the law across the country prohibits private care as you would understand it in the US. So that's one major difference. The other major difference, which is actually interesting, is even though we have a monopoly public healthcare system, just about all our doctors are free agents, private agents. They're not employees of the system, which makes running a public healthcare system extremely difficult. So even in the US, somewhere between 80 and 85% of doctors are employees of their systems. That's not true in Canada, and it really isn't true anywhere else in the world. So those are two main differences between Canada and the US.
Oh, that's great. And so let's try working some of the narratives here. So here in the States, Doc, the overwhelming narrative, it's probably correct, but healthcare system is broken. What's the narrative like in Canada? Are people generally happy with the system, whether it comes the patient side or physician side, healthcare side? Tell me what the general narrative is in Canada.
Yeah, well, so you have to take a step back and ask yourself, with respect to your question, why do people in the US think the system is broke? And most people would say it's broke because they can't afford it.
Right.
I suspect that would be the answer most people would give.
Correct.
In Canada, people would tell you the system's broke, not because they can't afford it, but because they can't get access to it. So that's the big difference. But in Canada, when you can get access to the system, I think the quality of care is generally excellent. And I don't think there's anybody who is dying or suffering because they can't get access in an acute, urgent situation. But you don't want to leave it to when you have one foot in the grave to be able to guarantee yourself access, right? You want to be able to go upstream and have access to preventive care, preemptive care, good primary care before you get yourself into any particular problem. And that's an issue here.
That's great. And so one of the things what I talk about with physicians and leadership here in the States is that and please tell me how this correlates to Canada, because in the States, there's attitude among doctors that I'm a doctor, not a leader. I'm not here to be a leader. I'm here to do my job. And there has now been a bit of a metamorphosis of doctors realizing that once they put in that lab coat, that they are leaders. But the one thing is, they're really not teaching leadership to doctors in medical school. I remember I talked to a doctor entrepreneur once years ago, and I said, during all these years of medical training, you're going years and years, nearly decades of it. Um, did anyone ever show you how to run an office, balance a spreadsheet, know how to hire people? And the doctor says no, because there's no freaking time for that. And that sort of connects to the leadership side. Like, they're not teaching leadership classes generally in a lot of medical schools here. They say, I think you are seeing that shift in Canada. What's the vibe there? I mean, are Canadian doctors see themselves as leaders? Is that same pushback there of I'm a doctor, that's it?
Yeah, I think it's probably the same philosophy, and where it comes from is the medical school curriculum, which is fairly typical across North America. Um, and you go to medical school to learn about human biology and to learn about disease, and then how to treat what you've just learned about, right? Um, you don't go to medical school to learn how to become a manager or to become a leader. And I don't know that you can teach anybody to become a leader. I think that's something you grow into with years of experience and going through your own trials and tribulations and learning from it. And I think learning is extremely important. But to expect that somebody's going to bake into the medical school curriculum, leadership training or management training, it's not going to happen. Those physicians who sort of discover themselves in that respect usually end up doing another degree. So they go in and do an MBA or the equivalent of an MBA or something. Um, but it's not different for any other profession. You look at the law curriculum in the law school; they're not turning out leaders or managers. Look in your own Congress, where probably most of the congressmen, congresswomen are lawyers. That doesn't mean any of them is a leader.
Right. So tell me about you and your leadership journey. What was there a moment in your career that forced you to rethink the way leadership is supposed to be in healthcare?
Yeah, well, there were several actually, and I think uh, training as a surgeon um, gave me a certain view of the world, which isn't the same view of the world a family physician would get or an internist would get. And I say that because a lot of what surgeons do, obviously, they do in the operating room, and so there's a team, an obvious team, and right away you become more, I think, aware in real time of the importance of systems and processes and teams and roles people play and how to interact with people and how not to interact with people because you got a patient line open on the operating room table and that's where your focus should be, and everybody needs to know what they're supposed to be doing, when to do it, how to do it. um, and so I was very early on sort of ingrained in thinking about systems. And the more years I was in practice and started to see the problems that healthcare presented to the population, it wasn't necessarily problems that were caused by individuals, but they were problems as a result of a system that was designed to fail, to be blunt about it. And after I had been in practice for about 15, 16 years, I got the bug to go back to school. Um, and I did a management degree, but I didn't do a typical MBA. Um, I went to an engineering school, actually, not a business school, and did a management degree in an engineering school, um, because they had a particular type of management degree that was geared towards engineers and scientists, and not towards accountants or lawyers or whatever. And the focus was on systems thinking, innovation, and technology, which is something that resonated with me. Um, and really, my interest in looking at the system from a systems point of view instead of from an individual physician's office point of view uh, just grew at that point. And I eventually moved into an administrative leadership role, um, and decreased the amount of time I was spending in my practice. And my first real leadership role, I guess, is when I became chief of surgical services at a major hospital here in Montreal. And about 6.5 years after that, I was named the CEO of that institution.
Now, in your book, Vision to Vitality, you talk about courage a lot, which is a little surprising because I think people understand the importance of surgeons and doctors, but they probably don't always equate courage unless you're talking about like pandemics or going into third world countries. Tell me about what courage looks like in healthcare.
Well, it's the ability to make decisions, timely decisions, for the right reasons. And, a lot of people won't do that. People don't wanna rock the boat. It's not worth my trouble. I can be doing something else, or I could be better remunerated doing something else. Why go looking for trouble? And I was always raised with the notion of doing the right thing. And if you're gonna have that idea buried deep inside you as part of your DNA, then you're going to have to make some fairly courageous decisions over the course of a career. You can't just stand back and say someone else will step up and do it and walk away. And I've never been the type of person who's waited for someone else to step up and do something that I could do and I should do.
And so let me ask, Doc, in terms of like your training as a surgeon to then becoming an executive, is it a left right brain sort of thing where um, maybe some of the training you had as a surgeon isn't great for being an executive or vice versa? Or was a lot of your mindsets and methodologies as a surgeon translate into leadership and leadership decisions?
I think a lot of my training as a surgeon and my exposure in surgical practice has helped me in my management job. I also spent over 30 years as a scientist, as a researcher, doing basic diabetes research, and so that also sort of gave me a mindset of how to approach problems in a rigorous data-based fashion, and which drives me today. I'm a very data-driven, evidence-based individual, um, and that's even more important today than it might have been 10, 15 years ago, because today the data that's actually available, um, and everybody sees it. So in order to make informed decisions, you have to have data.
And one of the things that you write about in the book is making the clear difference between complicated and complex problems. And as someone who's not as bright as you, sir, to me, complicated and complex sound like the same. So break those down, and how do leaders misread the difference in healthcare systems when it comes to complicated and complex problems?
Well, probably most people don't differentiate between the two of them, as you just indicated.
Yeah.
Um, something that's complicated could be a mechanical device, that has a lot of parts to it. And You look at the blueprint and you're trying to figure out how the thing works. I mean, that's complicated. But something that's complex is something that has a lot of interdependent dependencies. So you can't necessarily predict in a linear fashion what one thing is going to cause with respect to something else because it's not predictable. It's complex. So meaning nonlinear.
Got it. Okay, cool. And you tell the story about you spending a week living inside the hospital and how that became a defining moment. First of all, tell me this idea about living in the hospital. And I know a lot of doctors and nurses work these sort of like almost 24-hour shifts. It's been popularized by the TV show The Pit here in the States. But tell me about what that effect of you living in the hospital for a week did to you.
Well, so you have to understand that um, when most people think of hospitals, they think of activity that goes on from, say 8 in the morning to 5 in the afternoon, and to them, that's the hospital. But that's not the only hospital. The hospital after 5 or 6 in the evening is a different hospital. Hospital on weekends is yet another different hospital. And in order to really understand um, congestion in the hospital, uh, problems with discharging patients, patient flow is how we characterize it. You can't just be looking at 8 to 5, Monday to Friday, because that tells you very little. And I felt that if I was really going to get a good handle on the patient flow problems we had, which didn't only impact patient care, but it impacted the experience our staff was having and impacted our budget. I really had to experience the full 24-hour life cycle of a hospital across a 7-day week. And it really changed how I looked at the place. Because as I've said, the hospital at night is not the same as a hospital during the daytime. There's far fewer staff around. You're more likely to have problems because there are far fewer staff around. And if you try to find somebody responsible for something, it's a lot harder than during the daytime when you're fully staffed. And it's easy to talk about, but unless you've experienced it over the course of a week after having literally slept in the hospital and walked around for 24 hours a day, 7 days a week, you don't really imbibe what that really means. And it made a huge difference in how I look at problems in the hospital. It made a huge difference with respect to how I came to understand how people do what they do and why they do what they do, or why they don't do what they should be doing. Um, and my takeaway from that, really, and it may sound a little crude, but it was really what I saw, was what I called the absence of presence.
And tell me, well, before I want to get into the absence of presence, but before that, what did the people in your atmosphere in your universe, what did they think about this idea about you living in the hospital for the week? Did you think they were off? Did people think you were off your rocker? Were people like, are you sure you want to do this? What was the general reaction to folks when they found out you're going to do this?
Well, at first, I think most of them thought I wasn't going to do it. And then there was a group of people who clearly thought I was gone off the deep end. But once I started doing it and people saw that I was present, I think by and large, people were pleased to see that I was interested enough to actually want to learn what was going on. Um, I think that was probably the prevailing opinion of the nursing staff. I think there were probably some physicians who were a little less pleased because they thought I was there to look over their shoulder and make sure they were there when they were supposed to be there. So I understand that. But probably the most telling part of the week was the last night I was there. I went down to the emergency room, and our hospital has the busiest emergency room in the province of Quebec, bar none. And I was just sitting there, sort of minding my own business, and really didn't seem to be all that busy that night. And I turned to the what's called the unit coordinator, sort of the person who does a lot of the administrative stuff each shift. And I said to her, Have you noticed anything different this week? The week that I've been, walking around doing my thing. And she said, Dr. Rosenberg, it's very strange. I've worked here for 20 years. And this week was extremely unusual in that the patients seemed to disappear almost as quickly as they walked in, which actually told me a lot.
What did that tell you?
It told me that the doctors were more present, doing what they should have been doing, because they didn't know when I was gonna walk in and ask about what's going on.
That's funny. And so going back to the presence part, you stress accountability tied to presence. So what does physical presence still matter? And it seems like it matters. That's a great example of it. The fact that all of a sudden these docs like, oh God, the boss is here. So I'm gonna have to be really on top of these of the patients and get them moving and in and out of the hospital. So tell me about, that's a practical effect of it. But tell us like the larger effect of presence in healthcare.
Well, somebody needs to take responsibility. A patient gets admitted to the hospital, they're admitted to a physician, they're not admitted to a manager. So the physician needs to take responsibility. And, today, it's very common for a physician to say, well, it's not my problem. The team is caring for this patient. Well, that's just passing of the buck. Um, and that's something I have to contend with almost daily. Because most of the complaints of patients don't have to do with the quality of the care they get. It's with the lack of adequate communication.
Yeah, no doubt. And you mentioned the fact that when you were living in the hospital for the week, the physicians were more worried that you were going to be micromanaging them. So tell me about this idea of, and you talk about the idea of learning from clinicians rather than managing them. How do you do that? Because I feel like, especially physicians, they're like, hey, listen, I've got the training, I know what I'm doing. How are you able to manage them when they have that sort of air about them?
The issue has to do with trying to help them help themselves. And, yes, they're trained to care for patients and patients' medical problems, but those patients and their problems exist within a system. And physicians don't do a good job dealing with systems or working within a system because they're trained to be independent entrepreneurs. And that's a function of the socialization that occurs in medical school. And that's one of the things I would definitely change in a medical school curriculum. Um, but since it isn't going to change anytime soon, we've got to deal with it after the fact when people go into practice and show up to work in the hospital. Um, and everybody wants to do what's best for the patients. And if things are put into that perspective, then usually we end up arriving in a good place.
That's great. So when leaders finish your book, what single action should they take inside their organization within, say, the next month or so? Like, is there I don't want to say simple because there's nothing simple about being a doctor or a physician leader or anything like that, but is there something relatively easy that can be enacted without having to, turn the battleship in the bathtub?
Yeah. So, my style of management is really not to manage. um, I like to empower people. And in order to do that, you've got to surround yourself with the right people. And on the one hand, I could say I've been very lucky over the last 15 years as CEO here, almost 15 years. I've had an excellent group of colleagues. Um, they would say you have an excellent group of colleagues because you attract those people around you who want to work with you. Um, but I set a very high standard, exceedingly high. And as I said earlier, I'm very evidence-based, data-driven. So if people don't buy into that way of functioning, they don't want to work here or work with me. Um, but because the standard is so high, and because I manage by empowering others to do what they want to do and for them to become creative, that I think is the value add of having me run the organization. Because although people may come to me and say, "Can I do this or can I do that?" Whatever, um, they already know that I'm going to pat them on the back and say, "Go try." And I would be more disappointed if they decided they weren't going to do something than if they tried something, they failed, and didn't have the opportunity to do what they thought was the next big thing. So I'm a big supporter of people stretching to reach their goals, certainly on behalf of the organization. But I'm a big supporter of continuous learning across one's career. Uh, I do that for myself. I believe others should ingrain that in their own career trajectory as well. I don't think you could manage an organization like this today by being top down. And we've endeavored purposely to try to decentralize as much as possible what we do. And that bothers people, I have to say, because there are people who like to be managed. Um, and those people take up a lot of time. I would much rather have a group of very creative, energetic people who are self-motivated, who I can trust, who have bought into the vision, and then run with it.
It sounds like a big hack is hire the right people, right, Doc?
It all comes down to people. Yeah, absolutely.
That's great. And you can read all about it in From Vision to Vitality, Building Transformative Healthcare Organizations. He is Dr. Lawrence Rosenberg. Doc, thanks so much for the time. I really appreciate it.
Thank you very much. It's going to be a great read for anybody who picks it up. So I look forward to hearing what people have to say.
And that's going to do it for this episode. If you want to find out more information about Dr. Rosenberg and our other amazing authors, go to theauthoritycompany.com.